What's going on, guys? Tony here. Happy 4th of July. And in today's video, I want to talk about the hybrid, the combination of telehealth along with actual in-person mobile therapy. Now, whether you're a PT, OT, SLP, it makes no difference. If you're not implementing some version of telehealth into your practice model as a mobile provider, you're missing a huge opportunity. And one of the things that I like to always start with is, let's just start simple. The biggest complaint that I hear from both patients and therapists is patients just don't want to do telehealth. They can't do telehealth. The technology isn't really user-friendly enough for them. And so how can we turn that objection into an opportunity? Well, if you're already a mobile provider, I always say start with an in-person visit, set up the initial appointment, go to the patient's home. While you're there, you complete your evaluation, you develop your plan of care, you establish goals based on the patient's individual needs, and then before you leave, you establish the virtual connection, the telehealth connection. Now, there's tons of online platforms that allow a provider to start totally for free, HIPAA compliant. VC is one that I've been using more lately and I really like at the free level. So technology is there. We just have to be able to set it up and help the patient reduce the friction. Whether you're going to do it on a smartphone, you're going to hook it up to a TV, however you're going to do it, what is a vital component of that first session is that you make the connection happen. And you set it up in such a way that tomorrow, when you're going to do a virtual visit with the patient literally just has to push a button, turn on a device, something very, very simple. But a typical hybrid in-person and virtual model would look something like this. Now, I'm a physical therapist, so I'm going to approach it from a physical therapy perspective. Let's say, for example, if you follow any of my information about total knee replacements, you know one of the biggest barriers to individual starting outpatient therapy is they don't have transportation or it's hard to get into an outpatient clinic. In my area, I don't really think hardly any of the patients are receiving home health physical therapy after a knee replacement. Most of the knee replacements are done on an outpatient basis. So this is typically what's going to happen. My unique value proposition, what makes me, if I was a mobile therapist like you, what makes me different than everybody else is that I would create a dedicated total knee replacement program in which I am going to meet the patient either at discharge from the surgical center and help with the transfer into the car and just kind of supervise and answer questions. Or if I don't want that liability, I'm going to meet them at home. If I know that a patient's getting discharged from surgery at 1 o'clock, I ask the family to text me upon departure. This way I can meet the patient at the home. I can help with the transfer from the car into the house. I can initiate my initial evaluation at that point. We can negotiate any of the entryway barriers. We can look around the home. We can do a home assessment, do the, for me, physical therapy evaluation, plan of care, all of that. And before I leave, I establish that virtual connection, whatever the platform, whatever the device. This way, tomorrow, the patient pushes a button, turns on the machine, and I'm there ready for a 10 to 15 minute virtual telehealth visit. And then we do it again the next day and the next day and the next day. If I can't commute to their home or they don't require one-on-one 5 days in a row, I do 1 in person, I do 4 virtual. Depending on what I'm providing during the virtual session, at minimum, I'm answering their questions, I'm looking at their incision, I'm making sure that they're comfortable. There's always going to be things that are coming up. This might be billed under therapeutic activity. If we're reviewing home exercises, range of motion, it might be billed under therapeutic exercise. But regardless, let's work through the numbers, and I'm just going to do them off the top of my head because I don't have the ability to share my screen right now. But let's say that I do the initial evaluation on Monday. And typical reimbursement, outpatient Medicare Part B, it's going to be about $150. Then I go back on, let's say Monday was the initial eval, I go back on Thursday. It's about a $95 visit. Looking at those two, we're somewhere in the range of $245. Okay. And the patient was kind of on their own for the time in between. 2 sessions, billed Medicare, 7 treatment units, and 1 evaluation code. What would that look like in the virtual model? I would still have the initial evaluation. I would still have the $150 reimbursement, but then I would have 4 single unit sessions. In my estimation, most of what you're going to be doing is therapeutic activity, because you're going to be talking about transfers and positioning and things related to ADLs. So what's the reimbursement? We've got the $150, and then I'm going to estimate $40 a unit because we don't have the MPPR, which is a reduction for multiple procedures. And here in Ohio, average reimbursement for Medicare Part B is about $38. I'm going to round up to $40. So we've got 1, 2, 3, 4. 4 times 40 is 160, plus my 150. We're looking at almost $300, $290. And in reality, we ended up billing Medicare the same number of units. We did 1, 2, 3, 4 single unit visits, and then at the evaluation, we did 3 treatment units and 1 eval. So 7 treatment units, 1 evaluation. It's the same amount of cost to the Medicare system, whether I'm doing 2 visits or I'm doing 5 visits, but I'm leveraging and utilizing the technology. The other benefit, of course, my patient doesn't have to leave the house. I don't have to incur the travel cost. You know, if I was making a second in-person visit, that might be 20 minutes there, 20 minutes back, 40 minutes total of non-productive time. Whereas in this case, I'm using the telehealth system to allow me to be there 5 days, 4 days virtually, 1 day in person, but I only have 1 commute trip. So this is absolutely an opportunity for all of us, whether we use this while the PHE continues and while Medicare still allows private practice, outpatient, PTs, OTs, and then qualified SLPs to utilize telehealth. But even into the future, if you're a mobile clinician in the future where Medicare is no longer paying for telehealth services, I still think you could leverage telehealth functionality in a way that allows you to provide a higher level of service, do something that nobody else is doing, whether it be for cash pay or some other form of reimbursement. It's just a huge opportunity, guys. So let me know what you think. Let me know if you're already doing this or know somebody who is doing it. And if you're not, let me know when you start. I'll catch you guys later.